Come on in, get seated. As I said, I've got plenty of material to cover, and I'm trying to condense it into the time that I have allotted to me. So I'm going to go ahead and get started. My name is Dr. Doug Wingate. Some of you may have caught a couple talks that I've already given this weekend. I did the crash courses on microdosing, I did the crash course on the neuroscience of psychedelics, and then I talked yesterday on the 8-circuit model of consciousness. All of that's going to kind of thread together into this talk, but I'm going to try to lay enough foundation so that people who have missed that, if you did miss it and you're interested in those talks, reach out to me, and I've been recording everything and I can make it available to you. But today we're going to talk about radical neurology and the application of psychedelic-induced metaplasticity and neurorehabilitation. It's a lot of long words, and we're going to kind of break that down into what each portion of that means. To start, this is kind of where we're going to head with this talk. So psychedelics have been demonstrated to increase neuroplasticity and metaplasticity. We're going to talk about what exactly that means. Psychedelics have also been demonstrated to reopen critical periods of development. If you were here for my talk yesterday, we talked about that, but we're going to get into that with a little bit more detail today. This may include motor, sensory, and other types of critical periods. Yesterday I talked about this being more of the psycho-emotional development critical periods and social critical periods that have been researched with psychedelics. What we're going to take a look at today is how that translates into motor, sensory, and other types of critical periods that tend to occur, and that it may be possible to leverage the reopening of these critical periods paired with adjunctive interventions to elicit context-dependent relearning experiences. And we're going to talk about what all of that means. Akin to acute periods of neurological responsiveness and repair. So we're going to bring this into the realm of neurorehabilitation, which is where clinically I've been working for the last 15 years. I've been specializing primarily in traumatic brain injury and post-stroke. We're going to touch on each one of those. And also PTSD is often a co-factor in that. So work with a lot of PTSD, trauma work, and complex PTSD built into that as well. But today we're going to work more on the physical realm of side of things with neurorehab and eliciting acute periods of neurological responsiveness or repair. Okay, so opening of critical periods. We're going to go through just a few quotes here to build the foundation so we have at least a cursory understanding of critical periods, and then we're going to tie this into into neurology as we go. So there are developmental critical periods with exquisite sensitivity to environmental input. Psychedelics may remove the brakes on adult neuroplasticity. Neuroplasticity is the ability for the nervous system to become plastic or malleable or create new neural connections. And so there's been a lot of research in relation to psychedelics and its ability to upregulate or increase neuroplasticity. So it creates the ability to initiate change, inducing a state similar to that of neurodevelopment. And we're going to talk about the critical periods and how that neuroplasticity tends to wane later in life. So there are acute periods where there's a lot going on and you're constantly relearning a lot of new neural connections being made. And then as we sort of hit adulthood, a lot of that natural developmental neuroplasticity wanes over time. So what's being posited here is that psychedelics might remove that sort of genetic or built-in brake on the neuroplasticity. It might be that if what it feels like to be in that altered state of consciousness or that mystical experience that we think of with psychedelics is just what it feels like to reopen critical periods. This is a quote by Dolan. She is in doing a lot of the key work in critical periods right now. Talked a little bit about her work working with octopuses and giving them MDMA and seeing that it reopened critical periods of social development or sociality, and that her research has then moved more into the realm of how psychedelics influence humans in a very similar manner, both in terms of social critical periods, but also beyond that. So the ability to reopen the social reward learning critical period, where a lot of this research started by Dolan, and Nari was part of Dolan's lab. The ability to reopen the social reward learning critical period is a shared property across psychedelics, and they've taken a look when trying to find an underlying mechanism. So different psychedelics work on different receptors. Your classic psychedelics work on serotonin, MDMA works on serotonin and norepinephrine. They were looking for underlying mechanisms And it found that reorganization of the extracellular matrix of the cell is a common downstream mechanism. So reopening critical periods, this is some of the data that was came out of Dolan's lab. This is taking a look at a variety of psychedelics. So again, they started with MDMA, and then they tested this to see if the same thing applied to other psychedelics as well. So on the left, you have psilocybin, and compared to saline. That curve, that gray curve that you see, is what would be considered relatively normal in terms of neuroplasticity. And then you see at the top there, psilocybin is significantly above that. So you have an elevation or an opening of a critical period. Same thing with the middle one, that's LSD compared to saline, saline being the bottom dot, LSD being significantly higher than that. And then on the right, you have both ketamine and ibogaine. You can see that both of those are above the curve. Ketamine a little bit higher than ibogaine, but all of them significantly higher in terms of opening critical periods. This critical period reopening seems to correlate with the duration of the psychedelic journey itself, or how long the psychoactive effects are. So on the left, you can see how long a journey tends to be. The acute psychedelic effects tend to be, and then on the right, you can see the duration of the critical periods being open. So you have ketamine that has the shortest duration, and it also has the shortest window of critical period being open. And then as you move out, psilocybin and MDMA are fairly similar in terms of both duration of psychedelic journey, and the critical period being 2 weeks as opposed to 48 hours with ketamine. LSD is slightly longer than that. You tend to trip longer with LSD, and the critical period seems to be open for about 3 weeks. And with ibogaine, it's a very long experience. It can be anywhere from 24 to 46 hours or so. And that they tested, this study only went 4 weeks. So they tested at 4 weeks, and the critical period still seemed to be open at that. So they haven't tested beyond 4 weeks, just that with ibogaine, it did remain open for the duration of the entire study for those 4 weeks. Ravikar Harris, he is a prolific, if you're not familiar with his work and you have any interest in neuroscience and psychedelics, he's a prolific author and researcher, and he has the theory of rebus, relaxed beliefs under psychedelics, as well as the entropic brain theory. This is the idea that psychedelics introduce entropy into the system, the ability for that malleability and bring in the ability to initiate change. So this is a quote by him: psychedelics can bring about the revision of other heavily weighted high-level priors. This can be any sort of trauma or belief system that we may have, not directly related to mental health. This is in addition to mental health, so definitely in the mental health realm. But in addition to that, such as those underlying partisan and or overly confident political, religious, and or philosophical perspectives. That was more of the topic of my talk yesterday. So again, if that's something that you're interested in, get a hold of me. I'll get those slides to you or the recording. Getting back to some Dolan quotes, we are beginning to see lots of circumstantial evidence that the psychedelics are all doing the same thing or similar things in a way that suggests that the social critical period, or the social part of it, is irrelevant. That this is really tapping into the molecular mechanisms that are conserved across all different types of critical periods. So this is where we're headed in terms of branching out beyond the social realm. Really, what psychedelics are this master key for unlocking critical periods. There are lots of different critical periods. We're beginning to get a sense that many of the critical periods close using the same sort of governing principle. So we kind of already touched on that, just generally developmentally talking. These critical periods of development, they open for a period of time where we're very malleable and we're relearning a lot, and then they eventually close. And there seems to be an underlying mechanism to this closing of the critical periods, using the same sort of governing principle, the same kind of molecules, if not the exact same molecules, and will or have been implicated in the closure of, say, the visual critical period, which is very early in life, or the touch critical period, or the motor critical period. So this comes into play outside of neuro rehab in the realm of if somebody doesn't have enough visual stimuli when they're growing up. And so they've done studies of if you blindfold either a young child or mice, if a developing young being doesn't have enough visual input, doesn't stimulate the visual system enough, and that window closes, and it can create lifelong inhibition of the visual network, that it doesn't make up for itself later in life. So I mentioned neuroplasticity. If you've seen the other talks this week, I've already mentioned metaplasticity, but metaplasticity is a further delineation in neuroplasticity. It's the plasticity of plasticity, or it relates to synaptic plasticity, so it's been defined as a change in the ability to induce subsequent synaptic plasticity, such as long-term potentiation or depression. Thus, metaplasticity is a higher order form of synaptic plasticity. So what that means, and as it's relevant to the neurorehabilitation realm, is that there are a lot of different factors that influence how somebody is going to respond to a particular therapy, and how much neuroplasticity you can induce. So this can be substances that people have taken. It includes psychedelics. It includes anything from alcohol to nicotine, anything that can influence the nervous system and how it reacts. It can also be their state of mind. It can be time of day. It can be whether or not they're doing simultaneous tasks. So sometimes we'll have people doing dual tasking or multitasking at the same time that you're doing a therapeutic intervention. And that can be supportive, or in some situations, it can deter from the intervention being as effective. So that's sort of what metaplasticity means. It's just that there's a lot of different factors that come into play here. Psychedelics being one that influences metaplasticity. So, why does the brain have a sort of ready-made mechanism that psychedelics can tap into for reopening the critical periods? Why can we reopen them so easily if the brain wasn't already built to do this? And Gould suspects that it's because when we have these habits, they're adaptive so long as the environment is stable. So it behooves us to not be constantly relearning over and over and over again. If the environment and our life is relatively stable, then we can kind of create patterns that work well to be able to function. But then when there's a radical shift in the environment, then you can imagine that it would be adaptive to be able to reopen critical periods and relearn from your environment. So trauma, physical trauma, and we're going to get into traumatic brain injury and stroke here in just a little bit. Typically, the long arc trying to understand critical periods has really been focused around this idea that critical periods are great, but the fact that they close means that it's really, really hard to treat brain disorders in adults because the brain is no longer flexible and able to learn from its environment in the same way it was as a child. So, if we can understand the mechanisms, maybe we can figure out ways to reopen them for therapeutic benefit. And that's where we're headed. So, Gould-Dolan's work, this is a study that she is currently working on getting funded, and through Johns Hopkins in collaboration with Stroke Rehab Center within Johns Hopkins. It's the Fathom Project, Psychedelic Healing Adjunct Therapy, Harnessing Open Malleability. But it's a study focusing on stroke and how psychedelics may be helpful in reopening critical rehabilitative periods following a stroke. So the hypothesis of this is that by combining psychedelics with physical therapy in digitally enriched environments will restore the ability to recover motor function in stroke patients, even in cases where the stroke occurred months to years prior. And we're going to talk a little bit about what context-dependent critical periods means. We already talked about what critical periods is, but we'll get into the context-dependent portion of that. So generally speaking, this is what happens after a stroke. You have an acute period of time, it's relatively short, where there's a lot of neuroplasticity going on because your body is trying to heal itself. It's had a significant trauma, and the body goes into hyperdrive to try to rehabilitate that and create as much function as possible again, or rewire certain areas of the brain to recreate that functionality. So certain areas, neighboring areas of the brain will adapt and sort of take over some of that function that may not be as well as it was before the stroke. So you have the short period of time where you have the acute neuroplasticity and the acute healing, and it's a prime therapeutic window when you want to deal all of the physical rehabilitation, all the physical therapy, any sort of interventions to really try to leverage that neuroplasticity as much as possible to regain as much function as possible before that sort of critical window of neuroplasticity starts to close. So typically you want to get in there within 6 weeks to 2 months or so, where physical therapy is going to have its maximal effect or benefit for helping you to recover the motor function that you lost because of the stroke. That window closes just like all other critical periods close. People definitely have their acute care following stroke, and then there's post-acute care. And quite often, when people are coming to see me, they will be 6 months, a year, sometimes years out from having a traumatic brain injury or a stroke. So generally speaking, this critical window is long closed, and I have to have a very realistic conversation, depending on how far out they are from the injury, in terms of how responsive they may be, their nervous system may be, their body may be, and that sometimes, especially if that critical window has passed, any benefit that they're going to see is generally going to be significantly slower than if they started the therapy earlier. Well, an intro-directed trip with a lot of psychotherapy makes a lot of sense for PTSD and addiction and depression. It's probably the wrong context for stroke. It's probably not going to be the most effective way to go about things, because a lot of the issues that are coming up following stroke tend to be much more physical. So whereas doing a lot of physical therapy and movements and playing virtual reality motion games might be the right context for giving the psychedelic stroke, there's some really interesting evolutions and developments in VR-assisted physical neurorehabilitation these days. So goal is looking at bringing that into her study as well. And then we'll go ahead and move on to acquired brain injury, and stroke technically falls into this. ABI, you may have heard of TBI as traumatic brain injury. ABI is a broader term. So TBI falls into it, stroke falls into it, neurotoxic issues that may arise. There's a number of different things that fall into ABI. So it's a broader term that still has to do with some sort of significant trauma to the central nervous system or to the brain. So we're going to primarily use ABI, but again, if you see TBI as traumatic brain injury, they overlap. ABI can cause both focal and diffuse injuries to neurons, glial cells, and neurovasculature that can result in delayed symptoms that are notoriously difficult to treat. Sometimes people will have what's considered a mild traumatic brain injury, and mild means how significant the symptoms were at the time of injury. It does not account for significance or the duration of the symptoms long after the injury. So some people will have a mild traumatic brain injury and have very significant or debilitating symptoms for months, years, the rest of their life. While research investigating the efficacy of psychedelics in the treatment of ABI is limited, and a lot of this has to do with the fact that TBI and ABI have historically been disqualifying criteria in research studies because it's very complicated. So they're doing research studies in psychedelics, and they're looking at PTSD, or they're looking at depression. If somebody has a TBI, it's a lot more complex to suss out exactly what's going on. So they've historically been excluded from a lot of research studies. So the research is lacking. So we're going to look at what's out there and the direction that research is heading now that it is something that's being actively looked at. These mechanisms may contribute to cognitive and behavioral improvements in ABI. Efficacy of psychedelics in the treatment of ABI is limited. Their neurochemical and psychological effects offer promising prospects. So psychedelics show promise as they are neuroprotective and enhance neuroplasticity, including neurogenesis. This is the generation of new neurons or new neural connections and neurite outgrowth. Therefore, administering psychedelics during the acute phase of ABI could potentially mitigate subsequent complications. So that's in the acute phase, while their use during the chronic phase, post-acute, might help alleviate persistent ABI symptoms. So we're going to look at some of those mechanisms. The first being excitotoxicity. Excitotoxicity is where the neurons become hyperexcited and they start to fire superfluously or for no good reason. And this, when it's too much, it leads to cell death, and this is problematic. So it then leads to a dysregulation of many cell processes, which overloads the mitochondria being the powerhouse of the cell that creates all of the ATP, the energy that your body uses to do anything at all. So if the mitochondria are affected, your body doesn't have the energy capacity to do what it needs to do, or to heal properly. So insufficient ATP and excessive ROS, that's reactive oxygen species, and it leads to an energy crisis and cellular damage. There's limited research of the protective effects of psychedelics against excitotoxicity, but there is some. So it may buffer from stress by elevating oxidative capacity of neurons. Mushrooms in general are antioxidants. This includes any type of mushroom that has psilocybin within it. And there's evidence that the 5-HT2A, it's the serotonin 2A receptor that all the classical psychedelics work on. 5-HT2A agonists, such as psilocybin, have antioxidant effects as well. Another component that comes into play here is apoptosis, and this is a programmed cell death. This is a natural mechanism that your body is doing all the time, and it does it to make sure that there's proper die-off of your cells, that there's not unregulated overgrowth, or there's not, so this is something that helps prevent tumors from forming. If apoptosis isn't happening properly, cells go crazy and continue to divide, and it can lead to tumors and all other issues. So after an ABI or a brain injury, there can be a chronic elevation of apoptosis. Again, this is a situation where if there's too much or it's going on for too long, it's killing off too many cells, that's a problem. So there's also a potential link between post-ABI apoptosis and progressive neurodegenerative diseases that we'll talk about toward the end here. Psychedelics may decrease apoptosis by increasing BDNF, that's brain-derived neurotrophic factor, and activation of the TrkB and downstream signaling pathways. Just to note here that psilocybin and LSD both directly bind to TrkB and is displayed in affinity 1,000 times greater than antidepressants, such as fluoxetine, which is Prozac, and compared to ketamine. So TrkB also inhibits glycogen synthesis, or glycogen synthase kinase 3 beta. It's an enzyme that's implicated in cognitive decline through tau hyperphosphorylation, which leads to a buildup of neurofibrillary tangles and amyloid beta plaques. It's a lot of long words, but they're all implicated in both TBI, so traumatic brain injury, and it's also a hallmark feature in Alzheimer's disease and neurodegeneration. Okay, neuroplasticity we already kind of talked about, but just a couple quick notes that both high and low or subhallucinogenic doses or microdosing of LSD increase circulating blood levels of BDNF as early as 4 hours post-administration. Psilocybin effects on neurogenesis in mice are dose-dependent. Lower doses or microdoses have shown an increasing newly generated neurons, while higher doses have the opposite effect. So in terms of neurogenesis, in terms of neuroplasticity, the research so far has borne out that the microdoses have a greater affinity or a greater effect on neuroplasticity. Larger doses have a greater effect in global brain communication and allowing different areas to talk to one another that they hadn't previously don't normally talk to. So slightly different effects depending on the dose. The modulation of TrkB by psychedelics presents a novel mechanism with the potential to enhance and facilitate neuronal rewiring following ABI. MTBI just means mild traumatic brain injury. So that's concussion. Mild traumatic brain injury is associated with the loss of functional NMDA receptors. There's an elevation of glutamate by psychedelics that may restore aspects of structural and functional plasticity. ABI trigger neuroinflammation is another one that we'll look at. ABI triggers neuroinflammation within minutes to hours, very shortly after you have some sort of neurotrauma. There's inflammation that happens. This has a protective mechanism for a period of time, so it kind of keeps things under control, and it's the immune system responding and trying to heal itself. Again, when this becomes chronic or excessive, it becomes problematic. So it impairs brain function and contributes to secondary injuries. So the inflammation itself can actually cause further injury to brain tissue. Prolonged neuroinflammation can lead to lasting physical, cognitive, or behavioral or social effects, as well as social impairment. Psilocybin reduces pro-inflammatory cytokines, such as TNF-alpha, interleukin-1 beta, interleukin-6. Psilocybin and DMT have both been shown to modulate immune response markers. Psilocybin administered alone or in combination with eugenol demonstrated an ability to diminish various inflammatory markers. In that study, they found that the combination of the two actually was the most effective and had the greatest impact in reducing the neuroinflammation. The ability of psychedelics to mitigate neuroinflammation carries significant implications for the management of ABI. Okay, and then we'll take a couple, look at a couple network-wide brain changes. So certain areas in the brain don't work in isolation. Many of them work as networks and are communicating among one another, and there are a number of different brain regions functioning together for different functions. So on a more systems-wide look at things, psilocybin, LSD, DMT, and ayahuasca all seem to have similar acute effects on functional connectivity, synchronized timing of neural activity between distinct brain regions. So this is that global communication that I talked about. So all of those seem to have an affinity or an impact on allowing for better or greater global communication throughout the brain. Psilocybin, LSD, ketamine, increased spontaneous brain-wide signal diversity, psychedelic-induced amplification of crosstalk, that's the talking between brain regions that don't typically communicate, can lead to lasting changes in brain areas, bolstering cognitive processes, and positive shifts in mood. So all of that crosstalk and that global communication might be facilitated by decrease in thalamic gating. The thalamus is an area of the brain that takes in a lot of the sensory signaling. It's kind of a central hub that takes in a lot of signals and then divvies that out to brain areas. So as signals are coming in or as sensory experiences are coming in, it goes to the thalamus first and then goes wherever it needs to go, generally speaking. Also, for those familiar with anatomy, layer 5 parietal neurons in higher order cortical networks become more interconnected and flexible. There's an abundance of serotonin 2A receptors here and may be critical to cortical desynchronization. In some of the talks this weekend, in relation to psychedelics, the default mode network comes up quite a bit. As I said in the previous talks, this relates to sort of an inward movement or introspection. It tends to have an association with the ego, so there's a decoupling that happens between the frontal lobe and the default mode network under the influence of psychedelics, and this is associated with the experience of like ego death. So what they found is when people experience this ego death or ego loss, there's this decoupling. So this is sort of what's going on here. TBI-induced damage to white matter tracts of the salience network. Salience network is sort of a switch, a toggle switch, that moves between the default mode network and the central executive network. So it's sort of the external and internal cognitive processes of self. And so the salience network is impacted, which is also regulated by psychedelics and has been shown to predict emotional, cognitive, and default mode network dysfunction. Has anybody seen the study relating to ibogaine? A couple of you at least. So there was a recent study that came out looking at ibogaine within veterans who had had a traumatic brain injury. And what they did was they gave ibogaine in conjunction with magnesium and gauged their symptoms and their recovery, and it led to dramatic clinical improvements and a favorable safety profile. The favorable safety profile is significant because ibogaine comes with risk. It has a direct cardiovascular risk, and so they coupled it with magnesium in an attempt to mitigate that or reduce that risk. Because there have been heart attacks associated with ibogaine. Again, it's a very long psychedelic journey, and it takes its toll on the heart, and there have been some deaths associated with that. So ibogaine comes with its own set of risks, which is why it's not talked about nearly as much, because there's a lot of really interesting information in relation to ibogaine and opiate addiction. And if that's something that you're interested in, please look that up. It's really fascinating. But from this, further studies with state-of-the-art safety monitoring, because that's very important because of the cardiovascular risk, will be crucial to unlocking the potential benefits of this psychedelic compound. There are some clinical considerations that come in when it comes to working with TBI and ABI post-stroke as a whole. And so while research specific to the treatment of ABI is limited, the overlap in symptoms with those effectively treated by psychedelics, together with their neuroprotective and regenerative properties, suggest significant potential for the therapeutic benefits in ABI. Because psychedelic experiences can be overwhelming and emotionally intense, it's widely recognized that proper preparation before the journey and integration are essential safety and support components. They're very, very important, especially in this population, but just generally speaking, integration is huge and very important if you're looking to make any sort of real significant change or headway when utilizing psychedelics. But there's some significant, sorry the slide came out wonky. There's some significant limitations and knowledge gaps going on here though. There's a lack of longitudinal studies. Again, this is the result of TBI historically being an exclusionary criteria. So again, the research hasn't been done for a number of years. So longitudinal studies and how this plays out in the long term really hasn't been able to be borne out yet. There are questions around the durability of the effects. Again, this has to do with gauging long-term effects. There are financial barriers due to support requirements. There's ethical concerns in general, and this is a lot of the biggie that comes up when it comes to any sort of, particularly brain injury, stroke as well. Ethical concerns overall with the induction of a psychologically vulnerable state. Is it appropriate to have somebody who may be in a compromised neurological state, may have a brain injury, may be cognitively impaired, to go on a psychedelic journey? And that's a really big question. This article added to that is another approach, maybe the practice of taking subperceptual doses or microdoses for extended periods of time to potentially induce or increase that neuroplasticity without inducing the altered state. There are challenges with blinding participants when it comes to psychedelics, and of course there's advanced need for those facilitating anybody in an altered state. Again, I just want to re-emphasize that the biggie that comes up here is whether or not induction of the psychologically vulnerable state is appropriate for ABI, and be very overt that by no means is this pointing at a gross recommendation that psychedelics may be helpful. When I'm assessing what's appropriate for somebody in neuro rehab, as a whole, any sort of intervention is where they're at that time, what their body and mind is able to take in, and we initiate a treatment protocol that's appropriate for them. So for some, it's much more intense. Stroke, you have a little bit more leeway there, and you can usually work a little bit more intensely and try to maximize what you can within that window. When you're working with people who may be, again, cognitively compromised and traumatic brain injury, it takes a lot more in terms of a very thorough medical intake to determine what's appropriate for them. So it's not a gross recommendation. I do want to touch on neurodegenerative diseases real quick. There's a quote with psychedelics stimulate neuro and gliogenesis. We already kind of talked about that. Reducing inflammation, we talked about that. And ameliorate oxidative stress, we talked about that. Therefore, they are promising candidates for future therapeutics for psychiatric, neurodegenerative, and movement disorders. Importantly, psychedelics hold the promise of being disease-modifying therapeutics rather than simply just providing symptomatic relief. So maybe working more at the root of the issue than just providing symptom relief. I'm not going to go over this, but this is a big diagram that for those who are interested in neurodegenerative diseases and how psychedelics may come into play and the neuroscience of it, feel free to take a picture or send me an email, and I'm happy to provide these slides. But essentially, there's a neuroprotective element, there's a neurogenesis component, there's a neuroplasticity component, and then the potential to slow disease progression, as well as with microglia and reducing inflammation. So So their broad therapeutic potential, that means psychedelics, might result from an ability to rescue cortical atrophy, common to many neuropsychiatric and neurodegenerative diseases, by impacting neurotrophic factor gene expression, activating neuronal growth and survival mechanisms, and modulating the immune system. We didn't get into the immune modulating component of psychedelics. It's a whole other talk, but it does come into play here. This was just something that came across my way this morning. So there was a study relating to DMT and taking a look at Alzheimer's and some promising results there. So and this is super, super fresh, but because it happened to crop up and I was giving this talk today, I wanted to add it in, and it's got the link there for anybody who wants to look into the specifics of the study. But just that these are things that are now cropping up and are now areas of interest in terms of research and their potential in neurorehabilitation. So, while more research is needed to probe the effects of psychedelics in models of neurodegenerative diseases, the robust effects of these compounds on structural and functional neuroplasticity and inflammation clearly warrant further investigation. So that's kind of where we're at right now. There's not a whole lot of research to back it up, but there's a lot of interest, and if the research bears itself out, it would have a profound impact on millions of people's lives. There are millions of strokes every year. There are millions of traumatic brain injuries and acquired brain injuries, and neurodegenerative issues and diseases are a major medical issue and health issue. So just to review, psychedelics have been demonstrated to increase neuroplasticity and metaplasticity. Psychedelics have been demonstrated to reopen critical periods of development, and this might include motor, sensory, and other types of critical periods, such as those following a neurological trauma like stroke or TBI. We may be able to leverage this critical period reopening paired with adjunctive interventions or activities to elicit a context-dependent relearning experience akin to acute periods of neurological responsiveness. This is the stroke work, integrating physical therapy and movement exercises and VR assisted and everything, all of those nice tools to maximize the rehabilitation process. 78 Sanctuary is my psilocybin service center that I have in Portland, Oregon. Based on this research, I do provide macrodose journeys, but I also provide microdosing. And I have a 2-week microdosing program built in that is an option for people who are seeking these kinds of services. And some of the supportive interventions, as I said, I've been working in integrative neurorehabilitation for the last 15 years, and many of those tools I've used these just in the realm, regardless of psychedelics, as therapies that can be helpful in the rehabilitation. So these are things that are also offered to be potentially coupled, if appropriate, for an individual in conjunction with their either macrodose or the microdose regimen, depending on what they may be seeking and what might be appropriate. So everything from additional supplements, lion's mane is built in there, the statement stack is definitely give it consideration. I don't tend to use flushy niacin because niacin is used as a vasodilator. Some of the other natural substances that I've included there are also natural vasodilators without having the uncomfortable flushing effects that you can get from niacin. And then a whole host of other things, including some VR, including various stimulation methods to the nervous system. Audio entrainment can help with cross-communication through brain areas as well. These are all different things aimed at maximizing the therapeutic benefit and the neuroplasticity component. I have the VR and the hyperbaric oxygen listed separately because those are usually completely separate sections. So Oregon law, you can't do any simultaneous intervention anytime that you're administering psilocybin. So there's a minimum duration with microdosing, which is 30 minutes, where somebody has to be in their administration session, and that's it. But once their administration session is done, you can provide whatever services. So there's the administration session, and then any adjunctive methods that may be helpful for them. And then as final thoughts, I just want to bring to the attention that there's been a lot of studies in relation to the top is how the brain tends to be affected in depression. With that, the dorsolateral prefrontal cortex tends to be affected. That's key because it's also a very prominent area when it comes to traumatic brain injury. And there have been research studies demonstrating that you can gauge how well somebody is responding to therapy or healing along their TBI journey by how well the dorsolateral prefrontal cortex is responding. So there's a correlation there. And then at the bottom is brain areas that tend to be affected with PTSD. And that's an emotional trauma, right? But it has very physical effects. Certain areas of the brain become smaller, neural connections don't communicate as well. There's a very physical component of it. So while it is an emotional trauma generally, and that can definitely be coupled with a direct physical trauma, that at its roots in the long term, it is also a physical trauma. So these are overlaps between TBI symptoms and areas of the brain affected by TBI and areas affected by chronic or significant stress. And as you can see, there's significant overlap here. And even symptom-wise, there's a significant overlap in PTSD, and PPCS is persistent concussion syndrome, I think is the term that they use. But again, there's a lot of overlap here. So even though TBI has been used as an exclusionary criteria for a very long time in looking at how psychedelics may impact physical traumas, there are a lot of studies related to depression and PTSD, and those are not physical traumas. Those are also physical traumas. So there's some degree of translation that can happen there. Seven Gate Sanctuary, again, that's my contact information if you're interested in getting more information. If you want the slides, feel free to email me, and I'm happy to provide that or answer any questions.